Great. I'm going to mute my line and turn it over to Susanna Mazzardis. Susanna, take it away.
Thank you. Do you want to pull up the slides or shall I? Okay. Thank you, Chris. Thank you, everybody, for joining us this Friday morning. We had a great response to this webinar, so we're very excited to be with you all this morning. At least it's this morning here in Pennsylvania. I'm Susanna Massardis, and I'm the CEO for the Community Liver Alliance. And we have a particular interest in supporting 340B program reform. It's really important for our patient population, our provider population, and generally all of your communities as well. So I just want to give everybody a brief overview about what is the 340B drug pricing program, because it really can be confusing. And it is a federal program, and it's a drug pricing program that was established back in 1992, and it allows providers that serve low-income, needy communities to purchase medications at a very reduced price. And the program really helps to make medications more affordable and accessible for underserved communities. And the real goal, the intended goal with 340B is to maximize those resources and provide, the kind of care that people in these communities deserve, particularly federally qualified health centers. They are really the good guys. They're out there in the communities, in rural areas and in urban areas where there's a lack of resources and health care. So we want to make sure that we're properly supporting those organizations that are serving vulnerable uh, populations across the state of Virginia. Next slide. So the impact on the healthcare landscape. So basically, the 340B program enables hospitals, clinics to use these savings from drug discounts to fund their health programs. So they can continue to provide those existing services. They can use the money to enhance services. And so, for example, FQHCs may want to provide dental care or behavioral health services. We are thinking nutrition counseling. And so, we think about rural hospitals, and they're really reliant upon these savings to stay afloat, to make sure that they're able to serve the numbers of patients that are underinsured or uninsured. And without this program, the 340B program, some hospitals would struggle more than they already do. We know the struggle in these areas for these rural hospitals. And then we have the contract pharmacies, and many hospitals and clinics partner with different pharmacies to extend the medication access for these communities, and essentially for managing the chronic diseases and ensuring that there's consistent access to medications and these important therapies. Next slide. So there are some bad actors, and there are challenges and shortcomings for this 340B program, as you might well be aware, that there are geographic disparities, and some covered entities are located in wealthier, more successful urban areas, leaving rural communities without sufficient services. And there's a huge lack of transparency. Most covered entities are not required or do not self-report the 340B savings and how they use that, really raising concerns about, is this money really going to the true beneficiaries that it's intended for? And then there's inadequate accountability. Some entities prioritize their profits over, patients, low-income patients, and the services, even though they have this opportunity with this program to really fortify what they're able to do for needy communities. So these are our concerns and some of the things that we'll talk about, and not just about the shortfall or the shortcomings, but also the good aspects of the 340B program. We support this 100%. We just want to make sure that it's being used properly, that it's, being used for the intended purposes, and that we have transparency and accountability. Next slide. This is very small. So there has been media coverage, and we will provide these links to you. And it just demonstrates across not just Virginia, but other states of, how these funds work well and how they are being really improperly administered. So, and we also have a page on our website with recordings and data and articles and, other information. So we do have a nice warehouse of information for you after we're done with this webinar. So in Virginia, we'll go to the next slide. Let's talk about Virginia, since that's what we're here for. So we look at Virginia hospitals, and they've entered into almost 1,400 contracts with 340B pharmacies nationwide. And more than half, 58% of those contracts are linked to out-of-state pharmacies. And it raises questions. This happens often in many states, whether the program benefits local low-income patients as intended. I mean, there's plenty of, community pharmacies and pharmacies in our area. So why are we going outside of the state? And we know that 67% of Virginia hospitals provide below the average levels of charity care, and in some cases devote less than 1% of operating costs to charity care, despite capturing all those program savings. So, however, VA 340B hospitals earn 3.2 times more in 340B profits than what is spent on charity care. So, we really want to think about, how is this money being spent? Is it really going, again, back to the intended beneficiaries? And we want to know through reporting, because if you're doing all the things that you're supposed to do, if you're doing them correctly, you should be proud to report what you're able to accomplish with these funds. So over in the corner, we see that the University of Virginia Medical Center has 126 contracts with 47% of out-of-state pharmacies. And Clarion Medical Center devotes just 0.7% of its operating costs to charity care. And Inova Health, which encompasses Inova Fairfax Hospital, earns an annual profit of 115 million. So you can see the disparity in these numbers as we delve into them. Next slide, please. So there is legislation, 340B legislation, introduced into Virginia. It's Senate Bill 278. It was introduced by Kanan Svaranasov, and I probably said that completely wrong. But drug manufacturers permitting and registration certain conditions related to 340B covered drugs. So I'm not going to read all this to you, but we really we did send a letter from the Community Liver Alliance, and we really want to make sure that there's not an expansion of more contract pharmacies without having the accountability and the transparency. And we cited in the letter to legislators, where they could really improve and where there are, errors and how it's not being used to the maximum benefit for these folks. So we want to make sure that, 340B entities are certified cover entities and as defined in the relevant law. So we want to make sure that these 340B covered drugs that are being shipped does not impose requirements, exclusions, or reimbursement terms or other conditions on contract pharmacies or covered entities that differ from those applied to pharmacies or entities that are not contract pharmacies or covered entities. On that basis, that the pharmacy or entity is a contract pharmacy or covered entity, or that the pharmacy or entity dispenses 340B coverage drugs. It's a lot to say, but in short, it is really about making sure that we are transparent and accountable to the beneficiaries. And we're making sure that the benefits are being realized. Next slide, please. So we do have success stories, even though we know large hospital systems, health systems often are convoluted, and the transparency isn't always really shown and apparent. But community health centers, FQHCs, use these 340B savings to expand services and provide affordable medications and also not only increase access for low income folks, but also increase services. And you'll hear later from my colleague Clayton how that works when it's done properly. And then transparent institutions. Some hospitals publicly report their use of 340B savings, and they show the communities, what their direct reinvestment into patient services and how they're benefiting these communities. Next slide, please. So challenges. We have profit-driven practices that we just talked about that are not investing adequately in the money that they're taking and realizing. And there's resource misallocation. Some hospitals are really not expanding services for these underserved communities or uninsured or underinsured individuals, but they're paying salaries or, expanding into more affluent areas where these folks don't have access. So that's a problem. And then regulatory and legislative debates, these contract pharmacy disputes where, companies argue that hospitals and clinics are abusing the 340B program by partnering with many contract pharmacies, so many. I mean, you've seen the numbers. And that the third-party distributors of discount drugs are not reaching the patients, right? So we want to make sure that the patients are at the forefront of this program. And again, I can't say it enough about transparency and accountability. Policymakers are advocating for clear reporting, but they don't know all the facts. So that's why it's important for us to talk to you, for us to join together and talk to our legislators when they're thinking about this important legislation, that they're really doing the right things for the right people. And so these conversations are really paramount to the success of legislation that will continue to serve these populations and use this program the way it was originally intended. And so improving 340B for patients, next slide, we propose enhanced patient care with targeted outreach to, really enforce stricter reporting, and making sure that the equitable distribution happens for these rural and underserved communities, and that we're always reinvesting into patient-centered care, that we're thinking about the whole person. And the focus is on chronic conditions like liver disease and, for us, opioid addiction and liver cancer, et cetera. Next slide. So we have advocacy opportunities, and Clayton and I have been to many meetings in various states with legislators, holding briefings and individual meetings to really promote that the focus should be on patient-centered care, and that, we educate and mobilize support for reform with folks like you that have real world experience with these kinds of programs, and to host public events, let people know, to share patient stories. If you know patients that have benefited, we love to tell those stories to really connect the dots, particularly for policymakers to understand why this program is so important and to really have an eye on the accountability and the reporting. And so we also use social media. It's a great way to get the word out. So, if you're interested, we have social media posts and kits that you can use to help elevate these messaging. Next slide, please. I promise I'm going to stop talking soon and let you hear from others. But, next steps for advocacy organizations is to, join our group to collaborate and, let other health providers know, and to, talk to your communities. And we think about, many of these states most states are embarking on and have viral hepatitis elimination programs. This is a perfect opportunity to, really leverage screening and treatment for patients and folks with HIV or diabetes or heart disease. These are all the kinds of patients and providers that give care to these patients, that we want to educate about 340B, not just to use it, but to advocate for it and speak up to make sure it's not abused and taken advantage of. And join national movements. It is a federal program. So, really, a lot of this really needs to be from a federal perspective, but states can do something about it. They can enact transparency and accountability, and it's the least they can do to protect this program and engage in state reforms. Again, legislators want to know. We had success in New York where, through briefings and individual meetings, we were able to achieve a companion Senate bill and also new language to include the transparency and accountability. So it does work. It's not overnight. It's not, always easy or pretty, as as advocates, but we can make a difference in our communities. And we can do that by sharing stories and hearing from our colleagues. And today we have a special speaker. We have Dr. Harry Genwanter. He's at VCU Medical Center, Children's Hospital, and also Doctor is a part of the Rheumatoid Association. And so I want to invite Harry to give his perspective and talk a little bit about the 340B program in Virginia. Thank you, Doctor.
Hi, thanks, Susanna, for the opportunity to share my thoughts with you all. As the 340B program has just exploded over the past few years, and the concept of the program is absolutely wonderful. The idea is that medications that vulnerable populations require for their treatment for chronic or other conditions can be made available, and the entities that provide those medications do not go underwater purchasing the medicines so that they can actually help achieve treatment, because we know if you don't get a medicine, even if it's prescribed, it doesn't work very well. The problem with the 340B program is that it's been hijacked since its inception. The idea was that manufacturers would give deep discounts to entities that would allow them to be able to afford to provide these medications. And in return, the eligible entities would then provide charity care, presumably commensurate with what the discounts they were receiving, and that way they could stay afloat. The problem is that the hospital systems especially have found out that they can contract with numerous pharmacies, even out of state and hundreds of miles away, as Susanna noted, and obtain the profits from buying the medicines low and selling them high to the insurers. There's been studies that in the New England Journal, for example, that said that 340B eligible hospitals earned on average about $650, over $650 per unit. And then an independent practice that was trying to treat people with the same medication. So part of the issue, I think, with Senate Bill 278 is this is also true for the FQHCs. And so the bill asks that we expand the ability of eligible entities, to use contract pharmacies. Now, the problem with that is that it doesn't say where the entities are. It doesn't say that they have to identify the individuals who are receiving the medications and whether they are in fact vulnerable populations. And as was mentioned, most of these contract pharmacies are either out of state or certainly not in a vulnerable patient's area. Most of them, in fact, are in affluent areas. So the lack of specificity, the lack of accountability, and the lack of knowledge about who the medicines are going to, and the detailed data about how this money is being used is a huge problem because it's just getting aggregated. The other issue involved here is that a lot of the contract pharmacies are in fact owned by the big three companies that are involved with prescriptions in general. CVS, Walgreens, and Cigna and Walmart are all the ones that are receiving these contracts. So actually, the top five pharmacies, contract pharmacies in Virginia, are one Walgreens and four CVSs. So once again, independent pharmacies or the FQHCs are not getting the benefits of all these discounts, but again, the large corporate entities are. So one of the other additional problems is now independent pharmacies have difficulty staying in business because they are not going to be getting these discounts. And the same thing is true for independent physicians who are trying to, for instance, infuse medications for rheumatoid arthritis or treat chronic liver disease or other multiple sclerosis and other serious illnesses because we can't get the medications at the same price. And therefore, it's not, we can't stay in business and compete because the large hospital systems are getting these huge, huge discounts. So I think one of those, and we can get to this later about how do we improve this. And I think the concept that we're pushing is if you're going to expand the reach of contract pharmacies, everybody has to be accountable and prove that the medications are going to the people for whom it's intended. And the data cannot be just an aggregate. We have to know that you're giving the medicines to the right people. The article that sort of kicked off a lot of this from the New York Times about a hospital in Richmond actually is about a mile and a half from where I live. And there were no clinics there for oncology or a number of the other chronic illnesses for which the 340B medications were being purchased. They were in fact being shipped across town and used in affluent areas for other hospitals and entities within that healthcare system. That is not the way 340B was designed, and that's not the way it should operate. And so if we're going to be using these discounts appropriately, we all need to know how they're working. One other point, and I'll then let Clayton jump in on this, is that in fact, many times the hospital systems are using the 340B discounts for Medicaid patients and other state-sponsored programs because the profit margin is higher in the 340B. And so this again takes money away from the individuals who should be getting better care and opportunity to have these medications, and it's unavailable because of the lack of appropriate oversight and accountability within the program. And so I'll stop there and let Clayton tell folks about how it's supposed to work now that I've told you how it's not working, and we can move on from there.
Thank you, Doctor. We appreciate your perspective and taking the time to share this with our audience. And it is my pleasure to introduce my colleague, Clayton Rulli. Clayton is the CLA's Director of Strategic Initiatives, Mission Advancement, and Impact. So, Clayton, please take it away.
Thank you so much, Susanna. Thank you, Dr. Harry, for both of your comments and information regarding the 340B program. Let me be clear. We love the work that 340B has been able to provide many community healthcare centers and smaller nonprofits that are doing the work to provide care for individuals in both urban, rural, and even suburban areas. I think what everyone has made very clear, though, is that we need transparency and accountability when it comes to making sure that the money is going to, the patients and through savings, and also that organizations are using the money for charity care and expansion of services. I'm very passionate about the 340B program because I experienced the positives of using 340B as an organization and have seen how it improved not only the individuals that we worked with opportunity to access care and medications, but also the expansion of services, of an organization to provide more care overall. I am not a Virginian. I'm from Philadelphia, Pennsylvania. I worked at an organization called Prevention Point Philadelphia for the better part of 15 years. We are an organization, or we're an organization, they still are around, but it's an organization that works in harm reduction, basically working with folks with substance use issues, many folks who are unhoused, and high risk for HIV and hepatitis C. When you think about the enactment of the 340B program and you think of the year 1992, one of the major reasons why a 340B program came into play was because of the high rates of HIV at the time. This is not the manageable, treatable HIV that we know it now to be. This was literally, for many people, a change in life or an end of life. And so being able to empower providers to give, folks medications at a discount, while also being able to extend services for those in need was a very important thing. My organization got into the 340B program when they expanded it outside of the federally qualified health centers and other niche providers. Like I said earlier, we were a social service agency that was doing a few key services around reducing HIV and AIDS, as well as hepatitis C. We did a syringe service program. We did, testing for HIV and hepatitis C. We had a drop-in center where folks can get off of the streets, particularly when you're unhoused. That's a really big deal. And we also had acute medical care clinic where we would work with people who had wounds, cough, cold, people who needed medication assisted treatment, people who needed insurance so they can take care of some of their larger health needs. And one of those larger health needs that we weren't taking care of was someone who was HIV positive. We would typically send them to another location because we didn't have our HIV clinic, uh, HIV/AIDS clinic. When the 340B program, came into play with us, we were able to start that HIV clinic, knowing that we were going to be able to purchase those medications at a discount. And also be able to use the funding to hire the staff needed, not just around the HIV specific clinic, but also for the other programs, including case management, homeless services, and more. And so we started a program called Clinica Bienestar, where we partnered with a local AIDS service organization called Philadelphia Fight to provide HIV care. So basically, working towards being more of a one-stop shop for the people that we worked with, who are oftentimes stigmatized and judged for what they were doing and might not have felt comfortable going downtown in the case of Philadelphia or going to another area to receive care. That HIV clinic, which started with, I would say, two handfuls of people, over the years, continued to expand to where we had, over 50 patients in the program. So we expanded services because we were able to save the money with the medication and then put that money into, increasing our ability to serve people. But it's not just with the HIV care. Once we continued to do well, we were able to move to a larger space. So we went from like a 7,200 square foot uh, office in a basement to a 27,000 old church building where we had three floors. So we were able to use the funding that we received to expand services, and it was something that people could see and something that people can feel. Along with the HIV clinic expansion, along with our, newer building, we were able to, start a hepatitis C clinic. So now we're serving people for hepatitis C. We did a specific wound care clinic. We were able to hire more case managers, more testers, more peer specialists to work with people in a, unique and healthy way. We were able to open a low barrier shelter for folks who were basically in between getting their own place, through years of being unhoused. We were able to offer a transitional space for them until they could get, finally into their own homes. Um, I'm not saying that 100% of this was through 340B, but I will say a large amount of this was the flexibility that the 340B program was allowed. But it's important to note, our participants can see the changes that were being made. The neighborhood could see the changes that were being made. It wasn't a case where, we didn't see anything but our executive director or mine or other, administrators, salaries going up, but everything else looked the same. We were transparent in part because we were a much smaller organization, um, made to cross the T's and dot the I's on a regular basis. What this webinar, I think, is expressing is how important it is to make sure that all providers are dotting the I's and crossing the T's, whether you're small, medium, or large, but especially if you're large, because there's so many ways to reinvest that money into programming, or into people's, pocketbooks that we don't see because there's no ask for them to show us. So it's very important once again to, mention that we want the 340B program to continue. We understand that asking for accountability and transparency in the 340B on the states level is one part of the solution. It's not all that needs to happen. We know that we deal with a complex system, but I think it's very important, especially in this environment, to recognize that we need every dollar that's supposed to be given to the charity care and to the benefit of the people that we're supposed to be serving to go to the people that's supposed to be serving. And the 340B program has, over the years, been manipulated, particularly by larger entities. And that needs to stop because we know that there's a tax on health services, pharmacy benefits, and more that make working class and poor individuals have to struggle more than they should really have to. So it's a part of the solution. It's not the end all be all. It's really about just asking, as Susanna said earlier, if you're doing great work in the community, if you're giving back to the community, why would you have a problem showing that you're giving back to the community? Why are your, charity care numbers, around 1% in a lot of cases? Why aren't they higher? We don't need another urgent care in an area that already has 6 urgent cares when there's medical deserts in urban and rural areas that don't have but one urgent care, if that. You have people that have to travel 30 minutes, 45 minutes, an hour to get the health care that they need. And so, long story short, I think that asking for accountability and transparency is a really important thing. We need to make sure that folks can see the benefits from their perspective as patients, clients, or participants, how you, depend on or how you want to term them. But also that, the care is showing increased opportunities to reach people. And I was very privileged to work at an organization that saw that opportunity through the 340B program seized the opportunity and was able to expand in a way that I think, benefited the patients that we saw, the clients that we saw, excuse me, but also the community which we were in. Let me also mention that when we talk about like the contract pharmacies, like one big thing about the 340B program was when we did, work with the, contract pharmacies, they were local. They were mom and pop, pharmacies. And we continued to expand it to where, at least when I left, we had, one medium-sized contract pharmacy, but then we also worked with in the neighborhood about 4 pharmacies. So we could send you for your HIV meds, for your drug treatment meds, for your Hep C meds, for any other meds. We could send you to something that was literally 2 to 3 blocks down the street. And so you're building relationships with community pharmacies. You're giving additional opportunities for those pharmacies in the neighborhood to stay relevant, to stay with funding, to stay open. And I think that's really important. Like, there are many strides to, spend in the neighborhood. And I think, 340B program was an excellent opportunity to bring in those smaller, corner store pharmacies, and give them an opportunity to serve their community in a bigger way, which was great for recognition, but also great because financially, they were able to, obviously get some funding that helped them expand their services and pay their people more. And it was really important. So, we love 340B. We just want to make sure that the money's going to the right people. I've seen how it can be very positive in a smaller to medium size. And I think that it certainly can be in larger institutions, but show us your work. Show us what you're doing. So thank you very much, Susanna and Chris and Dr. Harry for letting me speak on this issue. It's one that I've witnessed and I'm very passionate about.
Mute. Thank you, Clayton. I always like hearing you talk about Prevention Point Philadelphia. I had an opportunity several years ago to tour and see all the great work that was built over all those years. And, it's such a great way to demonstrate how, when 340B program funds are, used correctly, the great things that you can do for communities. And Harry, thank you so much for sharing your perspective as well. The providers are on the front line, right? And we need to know from their perspective, how can we make this easier? How can we help serve patients better? We hear so much frustration from the provider side with, all the things you have to do to be a provider besides providing care. So I'll ask Clayton and Harry to unmute, and I'd like to invite the audience to ask any questions. Chris, I don't know if we have anything in the chat. I don't think I have access to the chat, but
Susanna,
Not right now. Nothing in the chat, no hands. But please, if you have any questions, please either put in the chat or raise your hand, and we can open the mics and certainly address any questions that you all have.
I did want to add, guys, that, when you talk about charity care and you're talking about giving back, like it's more than just medication sometimes. Like the ability to, have additional funding, could also be put into, providing for transportation, providing for, gift cards so that folks can get what they need at their, local store where they, get their supplies or get their food. So, I think the opportunity is more than just the medication. It's the ability to help people be a little bit more comfortable, while they're receiving the care as well.
And if I can just add, the point of all of this is the program was designed to be able to expand services. I mean, beyond just providing services, Clayton as so eloquently described. Our issues is that we really want to protect this program because the costs within the system all go up when you are misusing funds, especially funds that are authorized through federal legislation. So we want to make sure that only the patients who should get these medicines are getting them, to make sure they're eligible. We want transparency. If you're doing good work, as Clayton has said, prove it. And you shouldn't, you should be proud of that, and you should make a big deal about it, about how are you improving patient care. However you do it, it doesn't have to be direct medical care, as Clayton has so eloquently said. I mean, it can be housing, it could be all sorts of things, but show how you're using the money. And we want to make sure that there's not, we all need to make profits. I mean, a total nonprofit business goes out of business. You have profits are fine. Profiteering is not. And that is a concern that has been going on with this program that, we're talking, my memory is a little fuzzy, but it's like over $60 billion in 340B funds that have been used, and it's going to overtake Part D in Medicare very soon as the largest, prescription cost program in the country. So we need to make sure that no one's, double billing, that there's no arbitrage. Let's get back to basics. Let's make sure that the people who are supposed to receive these medicines and the entities that are supposed to receive these funds are getting those medicines and those funds, and that the funds are being used as they're supposed to be. This program has been hijacked because of a lack of oversight and a lack of requirements for detailed transparency. It's all done in aggregate. And as we all know, the devil's in the details. So let's make it better. Let's just not make it bigger.
Well said. If we don't have any questions or comments, we can conclude and give you some time back in your day. But Chris will be following up with an email and resources. And of course, please feel free to reach out to myself, to Clayton, to Dr. Harry. He's amazing, and he's right in your backyard in Virginia. So, we are your resource, and we're here to help support your communities and your patients, and, how we can help. Please let us know. We're, always willing to collaborate, and particularly for protections of vulnerable communities and patients. So, thank you. Speakers, thank you, Chris, for organizing this for us. Thank you, everybody who joined us on this Friday. We really appreciate it, and we hope that you have a great weekend and that the snow doesn't get to you like it has us in Philadelphia and Pittsburgh. That's where we're located. So, wishing you a great rest of the day and a great weekend. Thank you all so much.
Thank you,
Thanks for the
everyone.
opportunity.
Thank you, everybody. Take care.
Thank you.
Bye
Bye-bye.
now.